Change it around.
All right. Good morning. Any questions about yesterday's lecture? No? You guys are all experts on acute coronary syndrome? More or less? Less. All right. Honesty. I like it. I saw some of you guys at the gym yesterday carving out time for your physical and mental well-being. Ah, no pun taken. Uh, oh, you didn't see me? Salad. Good. All right. Today we're going to move on. So on Monday, we talked about a systematic approach to essential hypertension therapy. Yesterday, we talked about acute coronary syndrome. What is acute coronary syndrome? What is it? Yes, it's an inflammatory event. When you think acute coronary syndrome, what should you be thinking from a pathophysiologic perspective? Plaque rupture. Plaque rupture. There's coronary disease, there's atherosclerosis, there's stable plaque, and then there's plaque rupture. Anytime you think acute coronary syndrome, it's plaque rupture. That's important. I showed you a video of what it's like. I showed you angiograms of what it's like. So the management of plaque rupture is unlike the management of anything else. Yesterday in your small groups, you talked about stable angina, medical therapy of stable angina, but plaque rupture equals thrombosis. You have to go in there, get rid of the clot, and revascularize with a stent. All right, it's a very unique entity, and so you must know it. ECGs, you have to understand the coronary anatomy. You have to understand the ECG distribution of coronary arteries. You guys have a textbook. I saw it in Michael's office, O'Keefe. O'Keefe is a standard ECG book. Just gives you one ECG after another with an answer key. Get very comfortable with it. If you think I can teach you ECG interpretation in one 90-minute lecture, unfortunately, you are wrong. It is a lifetime of practice. Lifetime of practice. I'm still practicing in my career. Okay? You will be expected to know it. So understand ECGs, ST elevations, Q waves, and the coronary anatomy. The reality is sometimes patients with plaque rupture get to the hospital in time. They recognize their symptoms, they arrive in time, and you won't even see Q waves on their ECG. Their time to reperfusion therapy is so quick that on an electrocardiogram, even though they had plaque rupture, they will not exhibit Q waves on an ECG and suffer minimal or mild damage. The reality, though, is that many people do not recognize symptoms and they continue to infarct until something happens that brings them to the hospital. And you can imagine the greater the infarction, the later the presentation, you are going to see a sequelae of complications that then you must deal with, some of them being fatal. Okay? So that's what we're talking about when we're talking about complications of acute myocardial infarction. So I want you guys to be able to recognize the clinical presentation, pathophysiology, and management of three major complications: free wall rupture, interventricular septal rupture, or papillary muscle rupture. And I want you guys to understand the difference between a pseudoaneurysm and an aneurysm. 68-year-old woman, no medical history, who was quote unquote not feeling well for the past several days, started having intractable nausea and vomiting. Around 11 o'clock in the morning, she went to lay down, and 30 minutes later, when her husband went to check up on her, he found her unresponsive, tachycardic, and diaphoretic. He called her primary care physician, who told him to call 911. According to her husband, she had endorsed some intermittent substernal, epigastric chest pain on and off, but always stated that she felt much better after a few minutes. Her husband states that, quote unquote, she doesn't disclose much. 10-point review of systems, otherwise unremarkable. As stated, she has no known medical history. Surgical history includes a right ankle surgery in 2000. She has a 40-pack year history of smoking, currently at 1 pack per day, denies illicit drug use or alcohol use. She has no known drug allergies, and she takes no medications at home. Family history: her father had an acute myocardial infarction at 81. Mother had hypertension and dementia. Have you guys noticed that in these cases, there's always a prodrome of nausea, vomiting, diaphoresis? Why? What's that? Yeah, it's the autonomic nervous system. Plaque rupture, interestingly, has prosympathetic and parasympathetic syndromes. The nausea and the vomiting is which branch? Parasympathetic. The diaphoresis, the cold sweat, tachycardia, which one's that? Sympathetic. Yeah. So, EMS arrives. Patient's hypotensive. Good or bad? Bad. Yeah. Why is that bad? Yeah. Yeah. Cardiac output. Cardiac output. It's not great. Tachycardic. Good or bad? Yeah. I mean, it's physiologic. Remember, cardiac output equals heart rate times stroke volume. Where else have we seen tachycardia in the setting of hypotension? Reflex tachycardia. What drug? Clonidine, yes, but classically is which drug? Hydralazine. Hydralazine. Reflex tachycardia. Orthostatic hypotension. This is why we avoid hydralazine in the elderly. Yeah, so she's hypotensive, so the tachycardia is a compensatory mechanism. It's not great in the long term, but it's what's maintaining her cardiac output. She's satting 90% on 2 liters nasal cannula. She's lethargic, overweight, unable to answer questions, but able to respond to voice and sternal rub. So she's arousable. Neck is supple, JVD up to the angle of the jaw, regular, tachycardic, S1, S2 with 4 out of 6, holosystolic murmur radiating to the axilla. She's got decreased breath sounds bilaterally with bibasilar crackles. Her abdomen soft, non-tender, non-distended. She's got positive bowel sounds. She's well perfused extremities, no clubbing cyanosis or edema, unable to obtain a neurological exam due to mental status. You guys had murmurs yesterday, right? What is this? Why? Why does it go to the axilla? Pathophysiology. So where is the remember, murmurs are the sound of regurgitant blood flow, turbulent blood flow. No. What is the direction of the blood flow in mitral valve regurgitation? Into the left atrium. Where is the left atrium? It's posterior. It's posterior. So during ventricular systole, you have backflow into the left atrium, which is a posterior structure. So if you put your stethoscope in the direction of blood flow, that's where you should hear it. So if the direction of the blood flow is going from anterior to posterior, the stethoscope, you will hear it most clearly subaxillary, because now the bell of the diaphragm is in the direction of the blood flow, right? And mitral valve murmurs is very interesting because in many patients, in all patients, anything that increases the distance between the stethoscope and the heart will decrease the murmur. Because mitral valve regurgitation is a regurgitant murmur best heard posteriorly, in patients, what is interfering with your stethoscope? Chest muscle, breast muscle, cartilage, bone, adipose tissue? Anything that increases the distance between your stethoscope and the heart is going to diminish the murmur. What's really interesting, though, is that if you go subaxillary, that's when the skin begins to taper. That's when the adipose tissue begins to taper. That's when the breast tissue begins to taper. So when I hear mitral valve regurgitation, a holosystolic murmur on the left side of the patient, I follow it right into subaxillary, where the skin gets thinner and thinner and thinner, and the regurgitant murmur should get more clear. So it's a holosystolic murmur, best heard subaxillary. So you have a hypotensive, tachycardic, altered patient with a holosystolic murmur. What's the other interesting thing here? When your blood pressure is this low, who said shock? What kind of shock? Cardiogenic, correct. What on your physical exam would you find if the person is in cardiogenic shock? Huh? Not edema, but you're on the right side of the physical exam. If you're in cardiogenic shock and afterload is low, what would you expect the systemic vascular resistance to be? Huh? Hi. Why? What'd you say? I can't hear you. Brain. Well, you want blood to the brain and you want a circulatory blood pressure. So SVR is going to shoot up, and what it's going to happen is the body's compensatory mechanism is get rid of all extraneous blood flow and preserve vital organs. What are the vital organs? Brain, kidney, and heart. Bottom line. So on your extremities, when you touch the patient, what is the patient going to feel like? Cold, very cold and clammy, very specific for cardiogenic shock. This is in contrast to sepsis, right? Septic shock is what? The patient's hypotensive, but what's the SVR? Low. This is why in septic patients, when you examine patients, they feel what? They're warm. They're warm. Physical exam will tell you everything. What's interesting, at the point at which EMS got there, the patient's hypotensive, tachycardic, but look at the exam. Well perfused. She's not clammy yet. ECG. One of the first years. Where? What's the coronary vessel? Pick one of the other ones. Pick the last one. Right coronary artery. Let me remind you, you have to know this. Good job. It's a STEMI, right? ST elevation in 2, 3 in AVF. 2, 3 in AVF, RCA. 1 in AVL, V5, V6, left circumflex, V1, V2, V3, V4, anteroseptal, LAD. LAD. STEMI. Lesion, RCA. To the cath lab. You can see here, this is a left side shot. Large left main. Circumflex, LAD. What is the three-part definition of the LAD? It lies in the interventricular groove. It supplies the apex, not apex. It supplies blood to the apex, and it has septal perforators. It has septal perforators. And here you can clearly see this is the base, this is the apex, and this is the LAD. Large LAD, septal perforators. RCA. Where's the RCA? What is that right there? What is that? You're injecting dye into the coronary vessel, and you see this abrupt stop. What is that? It's not stenosis. Huh? Not ischemia. What is it? Yeah, it is the right coronary artery, but why is the blood not going through? Why can't you see what is it? What is it? What's occlusion? What has completely stopped the blood flow? Thrombus. It's clot. It's clot. Remember that picture I showed you yesterday? Thrombus. Take a catheter. That's the stent. You can see the remnants of the lesion. And look at that. You restore blood flow to the RCA. You looked at the ECG. You diagnosed the STEMI. You knew it was the RCA. It's plaque rupture. Go to cath lab, revascularization. All acute coronary syndrome leads to coronary angiography. After the procedure, the patient states that she can't breathe. Her oxygenation starts to drop despite increasing her oxygen level on her nasal cannula. She is quickly intubated for respiratory protection. What happened? Chest x-ray. Normal or abnormal? Normal or abnormal? Abnormal. Why? Too many white things in the lungs. Correct. That's problem number one. Too many white things. What's the white things? Fluid. Pulmonary edema. What is this large metal thing in the center? No. The endotracheal tube is actually here. See this line right there? What's this? Say it louder. It's trans transesophageal echo. What is that? A mic? Yeah. So remember, the atria are anterior or posterior. They're posterior structures. So a transthoracic echo goes through the chest. I just told you guys, whatever increases the distance between your stethoscope and the heart will decrease the sound of the murmur. Same thing with ultrasound. Anything that increases the distance between the ultrasound probe and the myocardium will make the images less quality. You got to go through fat, breast tissue, bone, cartilage before it even gets to the heart. When you do a transesophageal, they swallow a probe. It's like an endoscopy. But now the probe is actually in the esophagus. What sits right on top of the esophagus? What structure? What chamber? Left atrium. Where is the mitral valve? Between the left atrium and the left ventricle. So if you want to take a picture of the left atrium and the mitral valve, a transesophageal echo is a fantastic choice, right? Because on your exam, you heard a mitral valve murmur. Does this make sense? It's just anatomy. It's just anatomy. Okay? So you're absolutely right. So again, portable. The patient's unstable, intubated, so portable. Airway is midline. You see the ET tube and the TEE or transesophageal echo probe here. Patient is mildly rotated. Look at this massive pulmonary congestion bilaterally. You barely see the borders of the heart. You have a costrovertebral angle here. I don't see really a pleural effusion. This one obviously is cut off, so I can't see the entire angle here. Right hemidiaphragm is higher than the left because of the liver. So this is what we call flash pulmonary edema. Let me orient you. This is a transesophageal echo image. You will obviously not be expected to interpret these, but I do want you guys to appreciate what is happening at a clinical level. Here you have the left atrium, mitral valve, left ventricle, interventricular septum. A close-up here, this is the mitral valve annulus, but you see something flailing. What is this thing flailing right here? Huh? Yeah, it's something to do with the infrastructure of the valve. It could be a leaflet, and you're not quite sure. It could be part of the papillary muscle. You put some Doppler on it, and during systole, when the ventricle contracts, you see this massive backward blood flow into the left atrium. You see this turbulent flow coming this way? There should be no Doppler in the left atrium. ECG. She's in the ICU right now. She got her TEE. It showed severe mitral valve regurgitation. She got a stent to the RCA. Now take a look at her ECG and tell me what you see. Where? That's not an ST elevation. That's so take a look here. QRS T. QRS T. T wave inversion. Yeah. The ST segments have come down. You still have T wave inversions, but more importantly, what else do you see? Two waves. Guys, I ask Anytime I ask you about an ECG, I ask the same 4 questions. Really. Do you see ST elevations? Is it a late presenter or a early presenter? Anytime I ask you if it's an early or late presenter, I'm asking you, do you see Q waves, right? A Q wave is a downward deflection. If you have a downward deflection, can you have an upward deflection? No, no. So an upward deflection here is an R wave. A downward deflection, if it's going down, it can't go up. So if you have a Q wave, you can't have an R wave. Here, you have a Q wave in 2, a Q wave in 3, and a Q wave in AVF. So the patient now on her ECG shows a prior inferior infarction. This is the evolution of the ECG. There should be a graph. I talked to the ECG evolution with the seniors yesterday. Look at the graph and the evolution, the time evolution of the ECG. The ST segment eventually should come down, but if they are a late presenter, they will show the Q waves. Okay? If they present early enough, they won't have Q waves. If they present late, they'll have Q waves. I need you guys to recognize these Q waves on ECG. Yeah. QRS complex is this. If you have an upward deflection, that's an R wave. If you have a downward deflection, that's a Q wave. So this QRS is different from this QRS because this is an upward R wave and this is a downward Q wave. The downward deflection suggests a prior infarction. So, you were absolutely correct. That was a part of the mitral valve apparatus, and it actually was the entire papillary muscle. If you guys remember from anatomy, the valve structure is just one of the most amazing physiologic structures in the human body. Very compliant tissue with leaflets that are bound to papillary muscle. The papillary muscle attaches the leaflet to the left ventricle. In late presenters, you get infarction of the muscle, and with infarction comes necrosis. And with necrosis comes consequences, such as papillary muscle rupture. Approximately 5% of death in these patients usually occurs 3 to 7 days after the infarction. It could be partial or complete. Now, you guys yesterday talked about dominance and codominance. Because of the difference in blood supply, the rupture of the posteromedial papillary muscle is far more frequent than rupture of the anterolateral papillary muscle. And this simply has to do with blood supply. The posterior medial papillary muscle is supplied with blood from the PDA, while the anterolateral papillary muscle has dual blood supply from both the LAD and circumflex. Papillary muscle rupture occurs in plaque rupture. It could be ST or non-ST elevation MI. Most patients have relatively small areas of necrosis with poor collaterals, and up to 50% just have single vessel disease. Your clinical suspicion needs to be high. Acute onset of hypotension and flash pulmonary edema. Why do these patients go into pulmonary edema? Huh? Um, what was the first part you said? Graphic? Why is the blood not pumping out? Because of what? Yes. So the left ventricle is trying to maintain systemic cardiac output, right? But now you've lost the ability to shunt blood out the left ventricular outflow tract. What's the pressure in the left atrium? High or low? Low. It's low. So is it easier for the left ventricle to pump out the systemic system or into the left atrium? Left atrium. So all of a sudden you have complete loss of the mitral valve apparatus, and with every systole, blood is being funneled into the left atrium. And then through the left atrium, it goes into the pulmonary vascular circulation. Does this happen acutely or chronically? Acute. The body has incredible ways of compensation. Concentric hypertrophy, eccentric hypertrophy. The body just needs time to compensate. In these acute events, there's no time. That left atrium has no ability to handle the amount of volume that's coming its way, and it's going into the lung circulature. This is why we call it flash pulmonary edema. It occurs acutely. This is why she was intubated very quickly. Mhm. No, it's not all blood. I mean, remember, there's hydrostatic pressure, oncotic pressure in the lungs. So the remember, in these patients, what's the wedge going to be? High, right? So this is due to a left-sided filling issue. So it's blood, it's edema, and this is why they also have they have frothy edema. This is all interstitial edema that's coming out. The pulmonary circuit is very low. Okay, it can't handle a lot of pressure. So the clues here were that the patient was hypotensive, post late presentation of a STEMI, holosystolic murmur consistent with mitral valve regurgitation, and flash pulmonary edema. Early diagnosis is key here. Early diagnosis is key. When you get to hemodynamics, have you guys had hemodynamics yet? Or no, it's too early. When you get into hemodynamics, you're going to see a large V wave in systole. A large V wave on the left side of the heart is classic for severe mitral valve regurgitation. Echo. This is a diagnosis of echocardiogram. You want to take a look at the mitral valve apparatus, and you want to see the flail segment of the mitral valve and a severed papillary muscle or chordae. They always have a cardiac catheterization because ideally they need surgical repair, and the surgeon wants to know exactly what needs to be done from a surgical perspective. There is no medical therapy for this. This is acute severe mitral valve regurgitation, right? So the mortality rate is high. And so early diagnosis and call your friendly surgeon. Risk factors for poor outcomes after surgery. Obviously, the older you are, female, and poor left ventricular systolic function. If you've already suffered damage to the left ventricle, obviously perioperative risk is going to go up. Diagnose early, call surgery. Medical therapy, they tend to be unstable, right? She comes in, you revascularize her, everything was fine. She goes to the ICU, and then within a second, things change. So you have to somehow stabilize the patient. You diurese them because they're in pulmonary edema. So you start diuretics, and you need aggressive afterload reduction. Why is afterload reduction so important here? Yeah, you want more blood in the systemic circulation, right? The higher the afterload, the more difficult it's going to be. And this is why we talk about intra-aortic balloon pump. Intra-aortic balloon pump. If you can understand intra-aortic balloon pumps, you will understand this entity. So emergent surgical intervention requires treatment of choice for papillary muscle rupture. There is a high mortality rate with surgery. However, there is no effective medical therapy. So surgery is your only option. If you can repair the mitral valve, the surgeon will try, but if that's not able to be done, then they end up getting mitral valve replacement. Intra-aortic balloon pump. You have to know this. This is a device. It's just a balloon. You go through the femoral artery up the descending aorta. It sits in the descending aorta, and it gets timed to systole and diastole. Can you guess in systole, when the ventricle is contracting, what is happening to the balloon pump? Huh? It deflates. If it inflates during systole, what's going to happen? You're blocking all the blood flow down because you've inflated the balloon, and the blood's going to go right back into the ventricle. A hole in the balloon, there is no hole in the balloon. Okay? If it deflates, is it going to be easier or harder for the ventricle to pump? Why? Yeah, it creates a negative pressure. It deflates, creating a negative pressure, allowing the blood to go down. In a failing heart, is that a good thing or a bad thing? That's a great thing. In diastole, what does the balloon do? It's going to inflate. When it inflates and the ventricle is relaxing, what is it going to do? There's only one place it can go. Huh? Not the, you don't want it in the left ventricle. Where do you want it? What? In the coronaries. How does it get to the coronaries? Unbelievable. Good for you. Yeah, the aortic valve is closed. When the aortic valve is closed, you expose the coronary sinus. The balloon pump inflates, pumping blood back into the aortic valve, into the coronary sinus, increasing coronary perfusion. Is that a good thing or a bad thing? That's such a fantastic thing, right? Your comment of it going into the left ventricle is very dangerous because that is a probability. Do you want the blood to go into the left ventricle? Absolutely not. The left ventricle is failing. You're trying to offset the left ventricle, right? So tell me, what is a contraindication for a balloon pump? A disorder that will, if put in the balloon pump, it will increase the blood flow into the ventricle. Aortic regurgitation. If the patient has moderate or severe aortic regurgitation, intra-aortic balloon pump is a contraindication. No one cares if you guys know what an intra-aortic balloon pump is. No one cares. But you have to know physiology. Intra-aortic balloon pump is a fantastic way to test you on physiology. We use it all the time. We use an intra-aortic pump all the time. The uses of it is based on this medical knowledge. Do you guys have any questions? Okay? So, now that you guys know this, oh, this is just garbage, right? Augments flow and diastole, decreases afterload, and reduces ischemia. Shocker, right? Here is the balloon pump. You can see it's sitting right in the descending aorta. And this depiction is during diastole, it's expanded, aortic valve is closed, and it's pushing blood back down into the ascending aorta and into the coronary sinus, augmenting blood flow. Okay? Any questions? I cannot stress to you the beauty of the anatomy of the mitral valve, one of the most intricate structures in the human body. You have beautiful, compliant tissue. Here is the mitral valve, chordae tendineae, papillary muscle. This papillary muscle is intact, connected to the chordae, connected to the mitral valve leaflet. Here, papillary muscle, here's the rupture. In this specimen, complete rupture of the papillary muscle. If you lose the papillary muscle, you lose all integrity of the mitral valve. Ventricular septal defects. Where's the defect here? In the ventricular septum. Correct. Pretty rare, 0.2%. Usually occurs one day after infarction. Very high mortality. There is no medical therapy. Call your friendly surgeon. The mortality with surgery is 47% at 30 days versus 94% with medical therapy. Again, age, anterior, myocardial infarction, and female sex, greater risk factor. Comparing VSD to papillary muscle rupture, the location, the signs. Why is the sign of a VSD a low cardiac output, but the clinical sign of a papillary muscle rupture is pulmonary edema? There is a hole in the interventricular septum. Yeah. Fantastic. Fantastic. Yeah, the right ventricle is lower pressure than the left ventricle. And so therefore, you have shunting of the blood from high pressure chamber to lower pressure chamber. Whereas a papillary muscle rupture, there's no connection to the right side, but the low pressure chamber is what? If the low pressure chamber in a VSD is the RV, the low pressure chamber in papillary muscle rupture is the left atrium. Correct. Hemodynamics, there's a very unique thing that happens to a VSD. It's called a step up. So you'll get to hemodynamics, I'm sure, at some point, but we do this procedure called a Swan-Ganz procedure. You guys know what a right heart catheterization is? You take a catheter, but instead of going through the femoral artery, you go through the femoral vein. You take a catheter, you go all the way up into the IVC. From the IVC, you go into the right atrium. And then you sit in the right atrium and you take a little sample of blood. You measure the oxygen level in the right atrium. What is the oxygen level going to be? 0? It's deoxygenated blood. Yes, it's going to be low. Compared to arterial, it's going to be deoxygenated blood. Remember, the SVC and the IVC drain into the right atrium. You take a little sample of blood, you measure the oxygen, it's deoxygenated blood. Then you take the catheter and you go a little bit further. Now when you're in the right ventricle, and you take a little sample and you measure the oxygen. What's the oxygen going to be, high or low? It's going to be low. Still is deoxygenated blood because you haven't even gotten into the pulmonary circuit yet. Right? But in a VSD, when you're in the right ventricle, you take a sample of blood, and what do you find? It's oxygenated. Because now you have a shunt between oxygenated blood in the left side going into the right ventricle. This is what we call a step up. A step up in oxygenated blood. That's it. That's a VSD. Okay? Both of them require surgical intervention. So SVC and the IVC, deoxygenated blood. The brain is, yes. Yes, you should be able to detect it, but not always. Number one, transthoracic, very difficult. You're going through cartilage, bone, skin, adipose tissue, fat, all that stuff, right? If it's a large VSD, you should be able to see it. If it's a small VSD, you may not see it. Okay? But the reason why you're doing this is because your clinical suspicion is that you have it. Right? We don't do these procedures often, but we're looking, when we suspect it, we end up doing it. Okay? Good comment. IVC, SVC, deoxygenated blood. The SVC has a little bit more deoxygenated blood in it because the brain is just hungry for oxygen. Brain is able to extract a lot of oxygen from the blood, more so than the systemic circulation. You mix the SVC and the IVC, and then the RA, the right atrial sat, 68%. And then look, the RV sat is now 88%. That's what we call a step up. VSD. There's a connection between the left and right ventricles. You should hear a harsh holosystolic murmur. Why? Because now you have a shunt. And the shunt is from the left side to the right side. So in systole, when the left ventricle is contracting, it's funneling the blood into the right ventricle. Free wall rupture. Free wall rupture. Rare. More common in women, hypertensive, and older patients. Can happen in single vessel disease. The problem with free wall rupture is there's no clinical sign. 1 minute they're doing well, and then the next minute they have cardiac arrest. Aneurysms. Aneurysms. Left ventricular aneurysm versus a pseudo aneurysm. Which one is better? Pick the other one. Aneurysm. Aneurysm. If you are going to have an aneurysm, please. Huh? Have the real one. Have the real one. Post-myocardial infarction, LV pseudoaneurysm occurs when a rupture of the LV free wall is contained by overlying adherent pericardium. What's the pericardium? Yeah, it's a fibrous tissue around the outer layer of the heart. It's not outer layer, it's just surrounding the heart. And what's the point of the pericardium? Hmm? Yeah, good. It reduces friction, provides lubrication, protection, right? It does not affect systole or diastole. Is it thin or thick? Very thin, very compliant. So if you have a free wall rupture, the reason why a free wall rupture is so deadly is because now you have connection between the left ventricle and the pericardium, and what happens? Tamponade. Tamponade. What? What's a tamponade? Correct. Correct. Yeah. So the blood ends up accumulating within the pericardium. And remember, everyone is so obsessed with systole, right? Everyone is so obsessed with systole. Poor diastole is like the ugly duckling, right? Everyone's like, oh, half ref, half path. LV systolic function is what's really important. But the more you get into cardiovascular physiology, the more you appreciate diastole. Remember, systole only is effective if you fill the chamber, right? So if you are bleeding in the pericardium, the pressure in the pericardium goes up, can the ventricle can the ventricle fill in diastole? No. That's tamponade. When the pressure in the pericardium exceeds the pressure in the left ventricle. Boom. Cardiac arrest. So a pseudoaneurysm is a connection between the chamber of the heart and the pericardium, but you have not had tamponade. The only thing that is protecting you is the pericardium. Guess what the treatment is? surgery. Guess what the mortality is? High. Very similar to free wall rupture, very difficult to diagnose until it's too late. No. Why would it be protective? But there is no tamponade physiology. No. Cardiac tamponade is when you have so much blood in the pericardial sac that it begins to strangulate the myocardium. It can't fill in diastole. So tamponade is deadly. A pseudoaneurysm is a connection between the chamber of the heart and the pericardial sac, but there is no blood flow into the pericardial sac yet. They'll get there, but not yet. The reason why we call it a pseudoaneurysm is because it does not contain all three layers of the myocardium. That's why we call it a pseudoaneurysm. A true aneurysm is infarcted tissue that is no longer contracting. You end up getting fibrosis, but it has all three layers of the myocardium. Because it has all three layers, we call it a true aneurysm. Look at this. This is a pseudoaneurysm. A pseudoaneurysm is a connection between the heart and outside the heart. And here's a very thin layer of pericardium. True aneurysm? Typically, a true aneurysm has thinned out myocardial scar, usually from an infarction. Like I said, the infarcted segment becomes akinetic or dyskinetic, causing an area of stasis. That area of stasis is prone to developing thrombus. It's typically got a wide base, but because it contains all three layers, it's got low risk of free wall rupture. Pseudoaneurysm has a very narrow neck or a very narrow base, but the only thing containing it is the pericardium. This has a very high risk of free wall rupture. Apical aneurysms cause akinesis or dyskinesis of the apex. It can be detected by a cardiac echocardiogram. The problem with pseudoaneurysms in the acute setting is complete stasis. Remember, anytime there's stasis in the body, it's going to be prone to developing thrombus. If it develops thrombus and it embolizes, it can give you an embolic stroke. Sometimes when we find the thrombus, we start blood thinners to prevent embolization. Again, large transmural anteroapical infarction. And because it is fibrotic tissue, they're pro-arrhythmogenic. So take a look here. Here's the left ventricle. You see this little connection? There should be no red Doppler going past the wall of the ventricle. You guys see this? This is the wall of the left ventricle, and there's a small connection. Small connection. It's through the left ventricular wall. Does it got a narrow base or a wide base? Narrow. So what is this? Pseudoaneurysm. Take a look right here. So look at this chest x-ray. Can you guys see what's wrong in this chest x-ray? What's wrong? What is this? That's an aneurysm. Look at this. So this is what the surgeon sees. The aneurysm. They opened it up. Look at this massive clot. Look at this. Narrow neck. Massive pseudoaneurysm with thrombus. This is a LV gram with a cardiac catheterization. You inject dye into the ventricle. Look. Connection to the outer space. Narrow neck versus wide neck. So, complications to acute coronary syndrome, papillary muscle rupture, VSD, pseudoaneurysm, and a true aneurysm. Correct. No. A true aneurysm is when you infarct, late presenter, you infarct a portion of the myocardium becomes akinetic or dyskinetic and becomes fibrotic. When it becomes akinetic or dyskinetic, you develop a portion that's static. So when the ventricle in systole is supposed to contract, the weak area of the aneurysm does not contract. So if it is unable to contract, blood begins to pool in the aneurysm. It doesn't have a risk for free wall rupture, which is a good thing, but the problem is in the acute events of the infarction, due to the stasis in the aneurysm, you have the opportunity to develop a thrombus. If you don't diagnose it and don't put them on a blood thinner, if there is a thrombus, very high risk for thromboembolic events. Correct. Correct. Because in a true aneurysm, there is no connection into the pericardium. Right? That's what makes it better. There's no connection into the pericardium. Any other questions? Okay. Thank you.